Hi, everyone. Thank you for being here. Today I'll be presenting our postpartum depression screening practices presentation. And I'm associated with the Women's Health Institute at Robert Wood Johnson Medical School in New Jersey. So we'll be presenting on the screening practices in underserved populations in general, because in the US, this topic is very important because postpartum mental health is often overshadowed by maternal physical recovery. So, and also there's disparities among the screening practices and styles that they use. So, in our introduction, I wanted to define some differences between postpartum depression, postpartum blues, and postpartum psychosis, which is very rare. But postpartum blues is often onset around 2 to 3 days after the woman gives birth, and then it usually resolves after 14 days, whereas postpartum depression, the onset is within 4 weeks to 12 months postpartum. There's a very big difference in the amount of women who uh, do have these types of mental health disparities after postpartum, because in underserved populations, we found that um, postpartum depression affects 40 to 60% of women, whereas in every other population, it's only 10 to 20%. For postpartum blues, this often occurs in 50 to 80% of women in general. And usually the symptoms include tearfulness or mood lability and just mild anxiety. But there's no impairment in functioning for the mother herself. Whereas in postpartum depression, you often have all of the different symptoms that we go through in the DSM-5 that are according to the sleep changes, your activity, your guilt, and your energy, and your concentration status, and often talking about your appetite changes. With all of these changes, the mother often has impaired functioning, and also there's a risk to mother and infant bonding, which is why we wanted to hone in on this subject itself. For postpartum psychosis, this is rare, this is often emergent, and the mother experiences positive symptoms like hallucinations, delusions, or negative symptoms like confusion and disorganized behavior. Usually for all of these treatments, they require psychotherapy or cognitive behavioral therapy, or if they're placed on medications, SSRIs are the best option to also relieve anxiety as well. So the main pathophysiology behind postpartum depression goes with the HPA axis, which involves your estrogen and progesterone levels. So they say that in postpartum depression, there's a rapid drop in estrogen and progesterone levels, which destabilizes the serotonergic properties in general. So that's why if you have a dysregulation in your um, hypothalamus, pituitary, adrenal axis, then you're susceptible to these types of depression or psychosis. In these susceptible areas, chronic stress often leads to cortisol dysfunction. And if you often have limited social support or just support in general at home, bringing a baby home, this will amplify the mother's dysphoria and depression in general. So, why are underserved populations more at risk? This is due to their higher borderline stress levels in general, and also they have lower access to healthcare, and there's a higher prevalence in unrecognized prior depression that they may have never been screened for in the past. There's also structural inequities like poverty, racism, and transportation barriers too. So we say in our presentation that there's a biological vulnerability that interacts with the social determinants of health. And that's how the disparities in screening become very important. So, in our problem statement, we have that despite screening guidelines, we recommend universal postpartum depression screening in underserved communities, in particularly low income, minority, or immigrant women. They remain unscreened and undertreated postpartum. So, the key issues are limitations to maternity leave in general, and also the cultural stigma around mental health. And there's also a poor access to interpreters. So immigrant women may not have access to interpretation or proper translation in a healthcare setting. And that's why we go in detail with different types of postpartum screening tools. But the main one that I wanted to talk about was the EPDS, which is the Edinburgh Postnatal Depression Scale. This one talks about having um, lower cultural or language validity based on all of the other screening tools. But the EPDS is the most widely and recommended tool used worldwide, which is a 10 system self report type of questionnaire. And this questionnaire screens for not only depression, but also anxiety in postpartum women. And this is also available in lots of different translatable versions, which is why it's the most widely used. And it's most preferred because it takes less than 5 minutes to complete, and usually it can be done in the clinic, at home, or via telehealth. There's some issues though with this type of questionnaire, and it's in the epidemiological standpoint, where there's a lack of follow up in general for every type of screening tool that is used. There's often a lack of follow up with patients, which is why it's important to have an open conversation with the woman and also with her family so that we can get her the help that she needs. So, in our study objective, we wanted to examine the barriers to effective PPD screening in underserved population and also identify different interventions that we can use instead of screening tools. Like if any telehealth or policy changes, we can also reduce disparities by opening up a conversation with our patients. So in our methods, we used a mixed methods cross-sectional survey with interviews, and we were using this in mainly the Northeast United States, in the tri-state area around Pennsylvania, New Jersey, and New York. And usually we had employed mothers who were employed for over 6 months prior to delivering their child. And also they must have spent over a year in a underserved community. And the ages range from 18 to 45 years old. And the mothers were also 4 weeks to 12 months postpartum. We excluded any woman who had any prior psychiatric diagnoses, or we also excluded women who we didn't have any interpreter available. And we used the EPDS scale, and we had a power analysis of 80%, and we detected an odds ratio of 1.5. So we wanted to get a good sense of not only the clinical screening results, but also lived experiences from mothers navigating postpartum, and also the care, how it changed in their environment with resource constraints as well. And we had some really nice results where they said that PPD prevalence was significantly elevated in these populations. And they had lots of barriers like transportation issues, childcare limitations, language barriers, partially from the EPDS, and also a cultural stigma. So with telehealth expansion, then we were able to have a lot more of the population included, because telehealth, usually we are able to have a interpreter from all around the world. And also there was a problem with women having to take paid leave in postpartum and having appropriate coverage in their workplace. So, some limitations to screening itself talks about the self-reporting bias and also the selection bias. We are only targeting a certain population of women, and we also excluded a lot of women. So that's why there is a selection bias, and um, there has to do with most of the stigma and the limited interpreter availability, which is why our patient population was not that large. And also, some underserved populations have low sensitivity to the EPDS due to um, having prior psychiatric diagnoses itself. So we found that barriers to effective screening was our main disparity in this research. So we found that in low digital literacy with the EPDS, which is why the main community-based education needs to start with the physician itself. Um, Including insurance gaps was also a big thing with the participants because there were no follow-ups even when the screenings were positive. So that was also a big thing that we saw in our research. So in our discussion, we mainly talk about how medicine and social determinants of health are very intermixed because we have to reinforce that postpartum depression is very common for women, and it's not like it is a rare occurrence, and they're able to get help in healthcare if they are properly led there. So untreated PPD, we found that there's impaired maternal and infant bonding, and there's poor infant developmental milestones that were recorded. And also there's an increased risk of future major depression. So if they're not treated right away, then they could easily have a future occurrence when their child is older, not just 12 months postpartum. So, in our proposed interventions for how we wanted to correct these limitations is to improve screening tools, have multilingual screening. We wanted an integration into pediatric visits as well, like ask basic questions to the mother for the pediatric visits so that we're not only checking the child, but we're also checking on the mother. We also wanted to expand for telehealth because we found that telemedicine is very widely used in underserved populations so that they are not having any barrier to their job. And also, we wanted an initiative for community health workers, like home visits, education, and reducing stigma. So, along these policy level interventions, we wanted to also just recommend that EPDS is the best, it's the gold standard for the depression scale because it's only 10 questions and it's just limited by those language barriers. For two other tools, there's one PHQ-9, which is a very great tool, but it's just a general depression screening tool. So that's why it's not really recommended for postpartum. So, in conclusion, postpartum depression is one of the most common and treatable and deeply influenced by social determinants of health. So, our study highlights the critical gaps in screening among underserved populations and also the potential for an increase in telehealth visits. And also, we wanted to just improve postpartum mental health because it's not just a clinical responsibility, it's a public health priority. Thank you. I wanted to thank the Women's Health Institute for letting me present today.
Suran, yes, thank you very much. Thanks you for your